Good morning, good afternoon, or good evening, wherever you are in different parts of the world. Welcome to our first episode of the Australasian Pleural Seminar Series. This is our new initiative. It is a monthly online web-based meeting aimed to promote pleural interest and better pleural care, as well as stimulating pleural research. So we aim to provide a very succinct 15-minute lectures on a patient-relevant topic, and then we'll follow by another 15 minutes of question and discussions. This is our first meeting. It is work in progress. There has been a lot of organizational work that went on behind the scenes. We don't think that this will be perfect, and we welcome all your feedback and comments, and please email us afterwards. And also, if anyone has a strong interest and wants to present in this forum, please email us as well. To kickstart this first episode, we are delighted to have Dr. Dhaval Thakkar. He's an interventional pulmonologist who is lay clinic trained, and he came from America via Arizona to Western Australia recently. And he's very kindly taken up the first episode to talk about secondary spontaneous pneumothorax, which is a very common scenarios in secondary and tertiary respiratory care and often very difficult to manage. So I welcome Dhaval, but at the same time, we will have questions afterwards, but because of the large number of people, I'm seeing almost 100 people logging on now, we would have to ask you to type your question in chat. And if you can actually type in the questions during the talks, we will try to answer as many of them as possible. So without further ado, Dhaval, you can have the screen.
Awesome. Thank you, Gary, so much for the introduction. And I'm honored and excited to kick off this series. I think this is going to be a great initiative. So without any further, I'm going to load up the slides here that I have, and we'll get started. All right. So as Gary mentioned, today's topic is secondary pneumothorax, the non-surgical management of such. And so kind of three things that we'll discuss. Briefly, a medical history of pneumothoraces and lung disease a little bit, diagnosis, and then management. That's going to be the more relevant component of the talk. So briefly, I always like to talk about a little bit of medical history because I always find it fascinating whenever I give a talk. So, just starting back at 350 BC, Hippocrates realized that you could actually auscultate a hydropneumothorax by shaking a patient and listening to the hemithorax that was affected and hearing a splash, which we now know as the Hippocratic succussion splash. So that was 350 BC, quite some time ago. About 2 millennia later, René Laennec invents a stethoscope. So that really kind of changed the game for us in terms of diagnosis and kind of clinical exam. About 60 years later, Gotthard Billau developed a closed water sealed chest drainage system, which is basically what we use nowadays, just in a different format. And then about 100 years later, we have all sorts of different thoracic drainage catheter sizes and things available to, what we routinely use today. So you can see, kind of a long history, but realistically, just in the last few hundred years is when we've really started to be able to manage and assess these things. So just interesting to know. Diagnosis then, right? So just listening to people's chest, either with your ear or with a stethoscope after Laennec invented that. So I just always kind of find it fascinating with these paintings and pictures from history. But then moving on to now, how we do things. So radiographs are pretty obvious, CT scans as well. And I think, the newest technology, and I think something that we should all be using if we don't routinely, is ultrasound. And so this was a really good slide I found in a series that kind of shows a really nice pictorial description of what we expect to see for a pneumothorax, where we see barcode sign, where we just see the lines all along. And then going to lung point, which is over here, point 2, where you can see where the pneumothorax kind of ends and normal lung starts. And then the normal lung in slide D and image 3 here is the seashore sign, which is normal lung tissue. So, these are things that we should be routinely evaluating for, I think, right at the bedside, wherever we're called. And I think this has really changed the game of diagnostic speed, essentially. And so management, for secondary spontaneous pneumothoraces, definitive procedure of some sort is the recommended management, because the risk of recurrence is somewhere between 30 to 50%, so significantly higher than our primary spontaneous pneumothoraces. And so really, whether, if the patient's not a surgical candidate, then some form of medical pleurodesis or medical kind of management is advised. And so what are the medical interventions that we can offer? So chest drains being the most obvious, but then, definitive treatments would be chemical pleurodesis, autologous blood patch, which is, in its own kind of category, and then endobronchial valves, which are some of the newer technology in the last 10, 15 years that we've been using, and, still kind of working out in the algorithm where we should be and kind of how they fit into management and such. So I'll briefly touch on that as well. So when we talk about chest drains, one of the most important things I think, and I've learned kind of over my time, is that location is arguably the most important thing to kind of get a handle of. But it's also one of the more challenging things, because if anybody's put in, definitely any kind of Seldinger percutaneous drains, you know how challenging it can be to kind of make it go in a direction that you want it to. And even same thing with surgical larger drains, they sometimes have a mind of their own and will go kind of in the path of least resistance, which may not necessarily be where you want them to go. And so, talked about types of drains, surgical drains, so more rigid, larger drains versus the pigtails, the catheters with or without retention sutures that we have. And, depending on what type of drain we're using, will kind of determine the technique that we use, whether it's blunt dissection or a percutaneous Seldinger method. And then, the other thing consideration that comes into mind is size. So what size tubes are we going to use? So somewhere between 8 French to 14 French are kind of what we use for adults. They make 5 French catheters for pediatric patients, not something that I use, but are available. And the idea is that, the smaller drains are less painful. And then the larger drains obviously create a little bit more pain, but sometimes can be more effective. And, we'll talk about which situations may be helpful to use which size drains. So this is a chart that was, I thought, pretty helpful that we published in 2019 and during an article about pleurodesis. And so this is just kind of a brief kind of overview of different agents. We split into antimicrobial agents, cytotoxic drugs, bacterial agents, and then kind of a catch-all of others, including talc, nitrate, povidone, iodine, blood patch, and mistletoe. And so you can see in these, in the parentheses, these are some of the success rates. So, there are quite a few options out there. Some of it's going to depend on your location and what's available to you. But there are quite a few different pleurodesing agents. And there's no real great advice on which ones may be best or not. What I can tell you is talc is probably the best studied. However, majority of the studies are related to malignant pleural effusion. So not completely applicable to pneumothoraces, but, you can kind of infer from those studies. So some of the challenges and tips, that I can provide for chemical pleurodesis. So you need some level of lung and chest wall apposition to, increase your success of pleurodesis with chemical pleurodesing agents. Unfortunately, there's no clear answer to a minimum cutoff. It's kind of clinical gestalt, some experience, but we know that there has to be some level of chest wall and lung apposition for the pleurodesis to occur. And as I mentioned, agent of choice frequently depends on local availability and cost. I've pretty much used talc and doxycycline in my career training so far, and it's what we had available in the States. And talc is something that we use locally here, so that's kind of our go-to. The other important thing you have to consider is adequate pain control. So pre-medicating with lidocaine is very important. And then, post-procedure medications to have charted available for your patients, NSAIDs and opiates, because this can be quite painful. Everybody's a little bit different. Some patients, have a significant amount more pain than others, but, you have to definitely consider this. Moving on to autologous blood patches. So the data for that is a little bit murky, but it seems to be more robust in surgical literature for prolonged air leaks in post-surgical patients. The mechanism of action is, kind of unclear, but there's kind of a threefold thought is that the blood can go on the tissue and help form a clot. The idea is that it can also actually create a kind of a chest wall and lung surface. And then another thought is that the blood itself can be a pleurodesing agent, cause some level of inflammation. So don't really know, studies are, everybody's ready to study it. It's kind of ripe for the picking, but we do know that there is some benefit to that, but it seems to be more robust in the surgical literature. And, previous systematic reviews have shown that there's significant heterogeneity in different studies and protocols that people use. So it really prevents drawing any firm conclusions on kind of what to use, how to use it, when to use it. So a lot of this is just kind of clinical expertise and experience. Nowadays, the definition of prolonged air leaks, depending on what you read, can vary from more than 3 days to 7 days, kind of, which was the 5 to 7 days, which previous kind of cutoffs that people were considering. But now I think, even some of the surgical literature is suggesting, smaller number of days because patients are being discharged from hospital earlier. So those are one of the kind of components, the volume to use. And, a lot of studies suggest 50 to 100 mLs. Sometimes 1 to 2 milligrams per kilogram can be used. Obviously, you want to kind of be cognizant that it's probably ideal body weight and not just the body weight of the patient himself. And then there's some studies that repeat dosing of this. So really hard to glean anything from a lot of these things, but it is something, a tool in your arsenal to consider. And we'll talk a little bit about by when you would consider it as well. And so challenges and tips of that. So the good thing about blood patches, you can consider using this in patients where there actually is poor lung or chest wall apposition, and there does seem to be benefit in those patients. So you don't necessarily have to be obligated to use it in patients that have good apposition or the lung is completely up. The other component you have to really consider is the risk of pleural space infection. Blood is a good agent for microbial growth, and so you have to be cognizant that you may develop an infection in these patients. And then the last thing you have to consider, and it's quite important because this is some of the things that are pointed out in studies, is that if you're using smaller bore tubes, you have to worry about it being obstructed by blood clots. So being cognizant that you're maintaining the patency of the tube can be very important. But so those are a few things about blood patch. And so this is interesting, people may not know this. Something I picked up in training was a patient that has a continuous air leak, or even a patient that has a small tube and you're using a blood patch for, what you can do is you can actually hang the tubing over an IV pole as long as the tubing kind of goes above the insertion site of the drainage in the patient, and then put that on suction. And so gravity will hopefully keep your pleural-reducing agent within the chest wall and the cavity, in the pleural cavity, while letting air escape out and being able to be kind of suctioned out of there. And so this is another way, kind of another technique you can use to help your patients that may have a continuous air leak. And it's quite effective and works really well. And then so moving on to endobronchial valves. So in Australia, it's TGA approved, which is actually better than in the US. And so the FDA in the US has given endobronchial valves humanitarian device exemption for air leaks, which is defined as greater than 7 days following lung surgery. So very specific kind of group of people. That being said, we use them in patients with prolonged air leaks without that are not post-surgical. And looking at some of the studies, the success rate of using endobronchial valves ranges anywhere from 56 to 93%. So quite a range. And again, we don't know kind of where to use the valves. So a lot of the studies that have been done usually end up using the valves later in the course. And there's kind of internal data we've looked at suggesting that maybe we should be using these earlier. And so that's something that we're going to be looking at, in a trial format. There have been some trials that have tried to look at that, industry-sponsored study that was previously terminated because of difficulty recruiting. So didn't get any real data from that, but it's just a challenge with these patients. I think that we all see the challenges kind of managing. So challenges and tips of endobronchial valves. So in order to identify the lobar fissures, really need to have a good CT scan where the lung is up, which is usually very challenging in these patients because the lung is collapsed. And so you can't really identify the lobar fissure of where you may be able to, which lobe you may be able to target, especially if you don't see an obvious defect in the lung parenchyma. So that can be, that can pose a significant challenge when you're thinking about valve placement. What you can use are digital drainage devices that can give you a volume of measurement and a rate of leak. That can sometimes be really helpful. We've used historically methylene blue to inject it into a segment in the airways to identify the leak through the chest tubes. There's some data out there showing that you can use the Chartis flow catheter with balloon occlusion to determine flow, negative flow in isolating different segments. So you keep the suction on, occlude the segment and measure the negative flow essentially, and that can help you give an idea of where the leak may be and to help isolate kind of the area that you want to block off with the valves. And then additionally, if anybody's done these valves, patients, our colleagues that have done this know that as soon as a patient's anesthetized, they start taking smaller volumes, you lose the air leak. And so that can be one of the more frustrating things in the theater when you're prepping for these cases. But you can usually ask your friendly anesthesiologist to increase PEEP or provide larger respiratory volumes, for a period of time, and while you're occluding to see if you truly are occluding the right segment or if there's an ongoing air leak or not. It's not straightforward, but in the right situation, it can be really helpful for your patient. So something to, again, keep in your arsenal of tools to consider for prolonged air leaks and in your secondary spontaneous pneumothorax patients. So current states, kind of what I reviewed is that there's many options to choose from. However, it's really unclear which patients may benefit from which intervention. I did give you some kind of information as to which patients you may consider each kind of intervention for, but we don't really have great data. Some of it is just, due to recruitment and, challenging kind of management issues with these. But that's kind of where we are. These are what's available, and you kind of use what you have experience with sometimes, and just know that there's a few other things available, I think. So that being said, I'll kind of just review the complexity of managing some of these patients. And this was a fascinating case that we had, a patient that was here for a prolonged time. And so we have an 81-year-old male that came in with an incidental secondary spontaneous pneumo on the right side on a surveillance CT scan that he had done for metastatic squamous cell carcinoma. He had a squamous cell carcinoma of the left lung that responded amazingly well to chemotherapy and immunotherapy. And he was doing fine, and even when he came in for the scan, he was asymptomatic. We just got a frantic call from radiology and an oncology registrar about these imaging findings, and you'll see why they were a little concerned. But this was a CT, and so patient basically had his entire lung collapsed, however, was relatively asymptomatic. We did call the patient to come in and be admitted overnight and monitored, managed for this. But it's always impressive how much patients can tolerate without being symptomatic. So anyhow, he ended up getting an 18 French Seldinger or percutaneous drain. So you can see that on the left image. Went in, see a little bit of subcu emphysema. But you can see the lung came out pretty nicely. Looks like probably some level of re-expansion pulmonary edema happening in the right upper lobe. But you can also see a little bit more subcu emphysema kind of along this area. And so that was one thing that was a bit more complicating for this patient. And so when you're talking about managing these patients with air leaks and subcu emphysema, really your management options are, putting the patient on suction, considering an additional drain or a larger drain or better guided drain, getting your cardiothoracic team involved and considering a surgical intervention. And then if they're not surgical candidates, considering endobronchial valves, and then, somewhere along the lines, talc, if that's, if you can introduce that when you get the lung up. But those are kind of the management options we had for this patient. You can see that as we continue down his journey a few days into it, continue to have subcu emphysema, and it's kind of expanding onto the left side as well. And that was the more challenging portion because we had continuous air leak through the tube, but he continued to have subcutaneous emphysema, and it was starting to creep up his neck. And you can just see as we go down, just worsening. And you can see the other interesting thing is that now you're starting to see how much the subcu emphysema is affecting his, the tissue here, really kind of pulling on the tube compared to the left side, So you can see how much air is kind of filled in there and what effect it can have on the tube. Because remember, the tube is sutured to the skin, and so that becomes relevant in a few slides. But because he continued to have this subcu emphysema, we did end up putting a larger 24 French drain in to help help draw out more of the air and give it a path of least resistance as opposed to going through the subcutaneous space. And then, you can see we repeated a CT scan, and you can see our smaller drain and then our larger drain are both actually just stuck in fissures. And so you can see why they may not be as effective. And despite our best efforts of trying to guide them, as the lung came up, it just got trapped in the fissures. And so day 12 of our patient's stay, you can start seeing that, despite this larger drain, he's still having significant subcu emphysema, and we ended up putting endobronchial valves in him. So tougher to see on this projection, but right upper lobe, we ended up putting 3 valves and just closing off the right upper lobe because on CT imaging, there seemed to be some blebs up there, and that seemed to be the location. Trying to isolate the lobe was not terribly successful, as the patient stopped having a significant leak as soon as we anesthetized him, and so that was always a challenge. But we did end up putting valves in the right upper lobe in hopes that that would be the location. And so you can see that, there may be some effect of lung collapse. We were hopeful right in the upper lobe here that there was maybe some collapse there. But you can see continues to have subcu emphysema. It almost looks like it's worsening here. And you can see the reason why is that the initial 18 French tube has now come out. And so that was non-functional and actually probably worsening things. So we opted to take that out at the point and then placed another 24 French surgical drain in. And you can see that, again, has a mind of its own and ended up just going into the fissures, despite our best efforts. And you can see, the impressive amounts of subcutaneous emphysema this patient had. And so once we felt that there was some chest wall to lung apposition, we said, let's try some talc and see if we can get enough kind of pleurodist up to see if that would help his leak and the continuous air leak that we were having. Unfortunately, we tried doing that and it was unsuccessful. So a few days later, we said, all right, well, let's go into the right middle lobe and see if we can close off that upper lobe, because, we were having a tough time seeing if there was any fissure integrity between the right upper and right middle lobe, and frequently there isn't. And so we ended up going in and blocking off the right middle lobe as well. And again, during the procedure, as soon as we kind of put the patient under anesthesia, the leak improved. And we tried to kind of get it to, try to use larger volumes and try to use PEEP to augment that, and, still no real luck. And so we now blocked off his right upper and right middle lobes, effectively, really just his right lower lobe should be aerating than ventilating. However, you can see that, not terribly impressive on this X-ray in terms of lobar collapse. And so, this patient likely has poor fissure integrity between the three lobes and has significant collaterals, and prevented the endobronchial valves from being as effective as we wanted them to be. However, what we ended up doing was we ended up placing CT-guided percutaneous drain right in the apical area where there was a small amount of air kind of persisting there. And then we were able to talc up there, and that was successful. Finally, day 30, we were able to get a successful pleurodesis, and the patient was discharged a few days after, and is continuing to do well at this point. And we've opted to leave the endobronchial valves in him to avoid any obvious decompensation because of such a prolonged and kind of challenging stay that he had with us. And so you can see kind of how complex these cases can be. And one other thing that, I'll mention is the reason we didn't kind of opt to use autologous blood patches after his first set of valves went in, he ended up catching COVID in the hospital. And so we ended up having a leukocytosis and a CRP. And so to avoid, a concern of empyema or pleural space infection related to blood patch, we opted not to do that, because it would just muddy the picture a little bit and kind of cause more confusion. So we opted not to use that for this case for that reason. But, something that we could have considered otherwise. So again, just to kind of bring to an end my approach in 2024. So placement of chest drain, small versus large, depending on presentation, depending on patient. So patient size can matter. Like I mentioned, as the patient had more subcutaneous emphysema, it pulled the drain out. And so larger patients may have a challenge with percutaneously placed drains. So you may want to consider a larger or more surgical placed drain for those patients. And then clinical presentation, if the patient has a significant, air leak or a significant pneumothorax, and or you have a concern that this is going to have a larger leak, you may want to opt for a larger drain at that up front. The other important thing is to ensure that your drain is functioning. So I really strongly believe this requires consultant review at least daily. As much as I have amazing fellows and trainees, these are things that they can miss, and it can really kind of slow down improvement in your patients or be detrimental. But making sure that the drain is functioning properly, it's in the right location, hasn't migrated, isn't plugged, all these things need to be at least daily, if not more than once a day. I feel very strongly about that. So in the case of a pneumothorax, if the patient's pneumothorax is drained after your tube is placed, you can consider, pleurodesing. I use talc, but, agent of choice, whatever is available, whatever is that you have experience with, I think is reasonable. If the patient, despite placing a chest tube, has a continued collapse, you may want to consider upsizing the drain or finding a different location of placing a secondary tube. And if the pneumothorax is drained, I kind of define lung apposition as greater than 90% on chest x-rays, but there's ongoing air leak, you can consider pleurodesis using the technique I showed with the IV poles. And if there's continuous leak with no to minimal improvement, despite reassessing chest drains and making sure everything's appropriate, I think as early as day 5, I think it's important to consider valves, because there is some data showing that they're effective. Not only are they effective, but they kind of decrease the length of stay for your patients, which for some of these patients may be very, very important, especially a patient like ours who had a history of metastatic squamous cell cancer and had to spend 30 days in the hospital with us. Those are precious days for those patients. So anything to get the patients out of the hospital, I think, is worth considering. And so with that, I will end my talk, and happy to take any questions or thoughts or any comments, definitely from any of our colleagues across Australasia.
Thank you, Dhaval. Fantastic effort, especially to cover so much ground within such a small amount of time. We've got a few online questions. One of them is, what is the size of the drain? I think you mentioned that already, but what is the position? You prefer anterior second intercostal space or axillary safety triangle? Do you have a preference? Especially, I can probably act with the increasing BMI of our patients in general. Is there a particular preference by the patient's body size?
Yeah, no, absolutely. It's a great question. And so, yeah, like you mentioned, some of it does depend on patient body size, but also kind of the location of the pneumothorax. So I prefer the triangle of safety, just for bleeding purposes and such. And it tends to be a little bit more kind of out of the way for the patient as opposed to an anterior drain. However, like you said, a patient that has a lot of subcutaneous tissue kind of in that axillary line, it can be challenging to place a percutaneous drain, and those are fraught for being pulled and removed. So if you still want to utilize I think if you still want to utilize the triangle of safety, I would probably, in patients that have a lot of subcutaneous tissue in that area, I would prefer going with a surgical drain, or if you can, kind of the second intercostal space, kind of anteriorly placing it in that location can be definitely consideration.
Another question is, at what point would you add suction or at all?
Yeah, absolutely. So, I prefer kind of like, what we've shown in primary spontaneous pneumothoraces is to let the lung kind of determine what it wants to, when it wants to oppose and let it heal itself. Because we've shown that in primary spontaneous pneumothoraces, although that's a bit of a different animal, that I think the apposition of the lung tissue is important for healing. So if I can get away without suction, I prefer to leave my patients off suction and just leave it to water seal. The patients that I put on suction are the ones that have persistent symptoms, or if they have subcutaneous emphysema, for sure, just to kind of give that a path of least resistance to kind of move out that space as opposed to going into a subcutaneous space. Or patients that, despite putting a drain in, the lungs just not coming up, and the leak is larger than it can come out kind of passively. So those are the patients that I prefer, or I tend to put on suction.
There's a question, I think, maybe to repeat a little bit for the people who came late. If you still have an ongoing air leak, can you put talc in?
Yes, you can. Yeah, absolutely. So for ongoing air leaks, one of the slides I showed was using the tubing that you hang over the IV pole. So it has to be higher than the insertion side of the chest drain on the patient, but you can hang the drainage tubing over the IV pole, and so that way, whatever pleurodesicing agent you use will hopefully stay in the pleural cavity, and you don't have to clamp it because it won't leak out. And so you can continue, actually even keep suction on these patients, and utilize that technique, and that works very well in the right situation. So yeah, you can ongoing air leaks. You can still consider pleurodesis. You might want to consider blood patch for those patients as well. But kind of what local expertise can dictate some of that too.
So you mentioned that you need lung apposition to the chest wall for the talc pleurodesis, but live is never perfect, so it's never 100% apposition.
Yeah.
How much is enough for you to talc?
Yeah, that's a great question. I think some of it is just clinical Gestalt experience and how comfortable you feel doing these things. There's no good data out there. I mean, I think most agree that if it's, if half the lung is still down, probably not going to do it. 75% may or may not, right? But it all depends on what options you have available and kind of what your patient's been doing, how long they're there. Sometimes we, in this patient, we said, hey, let's try to talc this guy, even though the lung's not completely up. And it failed the first time, and it was successful the second time once we got probably better apposition. So I think, the case that I showed does kind of highlight the importance of apposition. But again, like you said, it's really tough to tell, kind of when. And in those patients that have subcutaneous emphysema, you can't even use ultrasound, which frequently you can utilize. So, and then irradiating this guy with CT scans indefinitely is also not ideal. So it can be very challenging from that perspective, I think. But yeah. So I think, ideally 90%, however you want to define that, I think, as small as you can get that. But yeah, I think it's a little bit for room for interpretation.
Yeah. And just for everyone who's still online, if you have questions, put it on chat for us. The next question is, what is your preferred pressure for suction?
Yeah. So again, I think, as minimal as possible. So I'll start at, and I use American units, but -5 centimeters of water. And then I'll go up to 10 to 15. And if I need more than that, I think if you, and you don't have a second drain or something, you should probably consider additional drainage or a better place drain. And then if you haven't got in touch with your surgical colleagues and kind of ask them to review it, even in the case if they're not great surgical candidates, they might be able to kind of help you and guide you a little bit too.
Yeah, so we really quite important to separate the difference for the audience. So a lot of the Australian hospitals, we use kilopascal. So 1 kilopascal is 10 centimeters of water. So important to separate the 10 centimeters of water that Dhaval just said. Don't give 10 kilopascal.
No, don't do that. Yeah.
There's a question about if you're working in a smaller non-tertiary hospital, what do you do when the patient has got worsening surgical emphysema for a pneumothorax patient?
Yeah, so this is something that Gary loves, and I'll put you on the spot a little bit, Gary, but the blowholes. And so you make these small incisions just in the subcu space, and you can actually squeeze out air. And if anybody's interested, I don't know if Gary, if you place them on Twitter, but we have some really good, fascinating videos of doing that for our patients. But you can really just make a small incision. They heal pretty quickly, where then you just make, 2-3 centimeter incision, just very superficially, and you can kind of squeeze the air out, and that can kind of pretty quickly relieve it. The problem is if you don't kind of fix the underlying problem, it'll just fill up again shortly after. But the blowholes can be very effective.
Yeah, I think the additional advantage for the blowhole is once you've already got lots of surgical emphysema, it's very hard to see if there's worsening ongoing air leak. And so if you don't clear the baseline, it's sometimes difficult on a day-to-day basis to see if it is still getting worse or has it got better. But I think the underlying thing is that you still need to correct the underlying air leak. If it is not coming out from the chest drain, you either need to make sure the drain is patent or replace it with another better position drain or even additional drains. I think there's a few other questions online. In the technique of inserting a chest tube, do you still use trocar?
Absolutely not. Yeah, no, I've gone away from that. I've never even used it. We had some drains, and I actually asked my previous hospital to remove them because we're a training institution, and so I just didn't want that to be in the hands of my trainees, because that's just fraught for problems, I think. Really, I think there's really no reason nowadays with Seldinger techniques or versus a blunt dissection. I find really no indication to use a trocar based device.
There's seems like a lot of questions about talc.
Okay.
Is there maximum times? How many times can you repeat the talc paradesis? What is the maximum cumulative doses? And the second follow-on questions on that is, if the patient still have an air leak, is there a theoretical danger of the talc going in through the hole into the lung and causes more damages?
Sure. Yeah. So to answer the talc, so in terms of talc, I mean, usually 3 to 4 grams, per time. And I don't know that there's an upper limit, but I probably would have, if it doesn't work the second time, I probably wouldn't try a third time. So that would get us to about 8 grams total. Yeah, so I think that's probably my practice. Again, no great data necessarily on that. And then in terms of the talc and the theoretical lung injury and ARDS. So some of that, the ARDS risk was when we were using a non-graded talc. And so now that we've switched to graded talc, and so the median size of particles about 25 microns, 30 microns, something like that. Really haven't seen the concern for ARDS from talc in that situation. And then the question of will that get sucked into to the lung that has the leak? Very unlikely, because it's got a continuous leak. So I don't really worry about that so much. And with the graded talc, as long as you're using graded talc, I haven't worried about ARDS or lung injury from talc itself.
Great. One question about blood patch. So you mentioned about infection, which is clearly a a danger, especially when the patient has got a tube that has been sitting there for days, usually by the time we think about blood patch. Any suggestion or advice on how to minimize potential pleural space infection?
Yeah, so I mean, besides obviously using sterile technique when you're doing that, so when you're doing the blood patch, you're getting blood from, either a venous source, and even there's been case reports of using an arterial line. I think the arterial line probably is maybe a little bit just smoother to use because you got a source there and you can easily aspirate, as opposed to trying to get it from an IV source, unless you have a PICC line, which is then ideal. But just making sure that that whole process is sterile, because you're switching around and things like that. So making sure that that is done under as sterile a circumstance as possible, I think is probably one of the more important things. And then in terms of monitoring, so monitoring these patients, using CRPs, doing that a lot more here than I did in the States. But utilizing a CRP and see, watching trends of rising CRP, leukocytosis, and those kinds of things, I think is important. In order to minimize, I don't necessarily use prophylactic antibiotics necessarily to prevent infection, but just close monitoring, I think, clinically and serologically, I think is probably the best we can do.
How long can we keep the chest tubes? Do you change them after a while? That's very interesting.
Yeah, that's a good question. Yeah, I mean, yeah, like the case I presented, 30 days, the patient had, majority of the chest tubes were in for at least 2 weeks. Yeah, I don't routinely go around changing tubes unless I'm, worried that there's something happening. Because I think the more you manipulate in and out, I think that's probably the higher source of risk of in terms of infection. So I'm not necessarily pulling tubes out just to maintain sterility or cleanliness of them necessarily. But it is, it brings up a good point as to making sure we're dressing these things appropriately and making sure that we're taking these dressing down and observing them. That kind of goes along that same, red bullet point that I put, ensure that you're managing and monitoring these drains daily. So, looking at these things and looking for pus, looking for sites of infection, induration, inflammation, any of that stuff is very, very important.
2 questions on endobronchial valve. One is, in the case that you just presented, how did you decide where in the lungs did you put those valves in?
Yeah, so it was, like I mentioned, it was challenging when you anesthetize the patients and they say they take small tidal volumes, the leaks just disappear, and it's very, very frustrating. But so some of that was we used his previous images compared to CT scans, and there was some blebs at the apex, and so that's where we presumed things were coming from, and so some of that was just kind of an educated kind of assessment essentially, and to some degree maybe I fooled myself a little bit or tricked myself into believing that's where things were coming from, because we did occlude the right upper lobe and then we did large tidal volumes, we increased PEEP and did that, and we didn't see any ongoing leak. So we felt comfortable and confident. That being said, it didn't work. So, for all that's worth. So we did end up using just balloon occlusion in that case. We didn't use the Chartis flow catheter. It's something that I kind of was thinking about as a result of that case. So I didn't use that, but that's something that's going to be in my tool belt, for the next time we see this.
And I think that is a very valid point, because nowadays when we're doing a lot more endobronchial valves, it does have an impact on the front line decisions of insertion of drains, because if you've got a bigger size drain, when you are actually going for endobronchial valve, it's much easier for the operator to actually be able to detect air leak than a 12 French gauge, especially if it is posterior and the patient is lying flat and on tidal volume anesthetized. Often my interventional colleagues like Dhaval or Rajesh will complain that they can't see the air leak, and that makes life difficult and maybe doesn't help them in deciding where to put the valves. So sometimes that might come into play these days, which is not in the standard textbook about considering of size of drains. And I think it is from New South Wales to say, how did you fund these valves in Western Australia?
How do we fund them?
Yeah, so this is, yeah.
Yeah. So I haven't been yelled at by anybody yet. I haven't received, maybe Rajesh has gotten emails about those. You're right, they are about $4,000 a valve. So they're quite expensive. But I think, the importance is, comparing it to hospital stay and that, I think, and that's what we need to look at. And I think that's what we're planning on looking at, when we do a small trial here. But I think that's the important thing to consider is, the cost upfront of these valves versus the cost of a hospital stay, and then the complications, right? So this patient developed COVID during the hospitalization. Thankfully, it was very mild, and he had really no symptoms except some fevers and, leukocytosis and such, and he did just fine with it, thankfully. But that there's more morbidity, mortality, kind of with a longer hospital stay. So I think that would be the thing that I would always just focus on if anybody came knocking on my door saying, why are you spending so much money on these things? But I think you're right. We do have to prove that with some sort of evidence. And how soon is too soon? Are we going to do this day 2, day 3? That may be a little bit aggressive. But we just don't know. We don't have the data. And so we've typically been doing, 10, 14 days if the patient's still stuck and we're not doing anything. That's kind of been our cutoff, just, locally. But I think, I'm an advocate for using these valves earlier, I think, because if we can get these patients out of hospital, even if it is with a chest tube in place with a Heimlich valve or something like that, getting them home so they don't get deconditioned. And if they have, a limited lifespan because of malignancy or something, I think it's so important to get them out of the hospital.
Yeah, so just to advertise that we are planning a small randomized trial on early use of endobronchial valves. If you're interested to be one of the centers, please contact us. Along the valves, another question is, how long do you keep them before you remove them?
Yeah, so typically removing somewhere between 4 to 6 weeks is kind of what we typically do, just because of the risk of infection and then granulation tissue, the valves eroding into the bronchial tissue causing hemoptysis and such. So typically we want to remove them by about 6 weeks. So that's typical what people will do. That being said, we opted for this patient to leave them in because, one, the patient was asymptomatic from them. And so if he does get symptomatic, we'll go fish them out at that point. But because of his, concern of limited lifespan, we decided that he's asymptomatic. He doesn't have any, evidence of infection. And in fact, subsequent imaging on him shows that there's essentially no collapse in his airway in his lungs. And so it's really not doing anything. He's still getting collateral ventilation to it. And so we've decided to leave it in him until he tells us otherwise, essentially.
Another great question. Will you do anything differently for transplant candidate or potential transplant candidate?
Yeah, so that's always going to be a conversation with the transplant team. I think there's always, important to communicate with the transplant team because it's going to impact what you do, especially if there's empyema risk. So probably in those patients, I'd probably avoid autologous blood patch just because of that minimal risk, whatever that is. And then again, trying to minimize how much you manipulate those tubes in those patients, especially if they're, pre-transplant. The post-transplant patients, I'd be, impressed if they had a prolonged air leak, unless it was post-surgical kind of related, because they pleurodese those lungs so well. I remember doing transbronchial biopsies on post-transplant patients, and you could try to cause a pneumothorax and you'd be unsuccessful kind of thing because they just pleurodese so well afterwards. But yeah. So I think, minimizing risk of infection is probably the utmost important for pre-transplant candidates, I think.
Question about, have you ever tried CT-guided percutaneous intervention, for example, tissue glue sprays?
Yeah, so I haven't tried those. We have there's something called a tissue fibrin sealant that we've used for other patients for different indications, but I haven't used those. I think the valves, the reason I like the valves is because they're reversible. So if the patient has issues and they start getting pneumothoraces or they're more symptomatic, we can just take those out. So I like the reversibility factor of that from an endobronchial perspective. And then to answer from the outside in, we have amazing IR colleagues here, so I think they'd be willing to do it. The problem is you can't really, unless it was towards the end of that patient's case, we're just in a, kind of a loculated area or a smaller area. It's tough to say that, putting a sealant in is going to go where you want it to go kind of thing. So just kind of for that reason, I don't think I've necessarily, put that on my front line of use.
And maybe the last question, do you ever give preventive or prophylactic antibiotics for people who has a chest tube for quite a number of days?
Yeah, that's a good question. I mean, it's something that we're looking at for our IPCs, right? And so I think data from that will be maybe a little bit more telling, but no, typically not using that. But, I don't know that you could go wrong with putting some topical antibiotic there. I don't think there's any, you can be faulted for that. And I think it's probably reasonable. I just, from the times, even for this patient that we had all these drains and manipulated him a few times, he didn't have any, the tissue there didn't look infected at all. And so we kept a close eye on things, obviously, but I haven't had very many patients, even with, the few patients that I've taken care of with prolonged, air leaks and been in hospital for a long time, developing infection at the skin site. And I think some of that is just, local management and kind of keeping an eye on it, regularly, and making sure your nursing staff is helpful for doing that as well.
Okay, I think we're exactly 45 minutes. We promised to stop at that point. So I'm overwhelmed with the very positive responses. We have almost 200 people at one point, and there's still 140 people online at 45 minutes. I'm very impressed. Thank you so much, Dhaval, for insightful talk and answering all these very practical questions. And for the audience, we will aim to make this a monthly thing for every month, usually at the first Wednesday of each month. I know today is not, but in the future. So the next one will be the 6th of March. And Dr. Deepan Sivakumar, who is in New South Wales, is going to talk about IPC management, especially with his newly published optimum randomized trial results. So we'll see you then. And please send us all feedbacks and suggestions. Thank you very much for joining us today. Have a good day.